Good evening, everybody. I'm Chief Bioscientist Dr. Jayatri Das, and welcome to tonight's program. From COVID-19 to rovers on Mars, to winter storms and electric power grids, I feel like the headlines this week has really kind of encapsulated how science and technology are shaping our lives every day. At the Franklin Institute, we're here to bring you opportunities to think about these big questions and what they mean for our society, and to explore the wonders of science that bring us together. So first, before we get started, I want to thank you for your support. As members, you're our most enthusiastic fans, our most frequent visitors, and really the heart of our museum family. We couldn't have made it through this past year without you. I think one of my favorite things about being at the Franklin Institute is that we're part of such a rich community of science here in Philadelphia. And we're lucky tonight to have a special opportunity to talk to one of the leading experts in public health and science policy from just across town. Dr. David Rubin is director of Children's Hospital of Philadelphia's PolicyLab, and he leads an interdisciplinary team of researchers and communications and policy professionals who work with physicians, schools, communities, and other stakeholders to develop programs and policies that support child and family health and well-being. And all of that involves so many questions that we're wrestling with during this pandemic. He's been both an invaluable and a tireless resource for people and organizations throughout this crisis. Just from my personal experience, my family's school district, like many others in the region, have been relying on the PolicyLab's guidance as we try to make decisions in the face of uncertainty. So tonight, he'll give us some insight into how his team thinks about predicting the pandemic and what those predictions mean for the real world. Just a few housekeeping notes before we get started. Thank you to everybody who submitted questions in advance. We're going to start with a short presentation from Dr. Rubin, and then our conversation will be guided by your questions. If you have additional questions, please go ahead and put them in the Q&A box. We encourage you to use the chat as a place to share your thoughts and experiences, but we'll kind of be keeping our eyes on the Q&A as a place to look for specific questions to answer, and we'll try and get through as many as we can. And so now, without further delay, Dr. Rubin, I'll turn it over to you.
Yeah, thank you, Jayatri. It's a pleasure to be here with the Franklin Institute tonight. As I thought about this talk tonight, there's a lot that's already out there. There's a lot we know. There's a lot we don't know about this novel coronavirus that we've been struggling with for the last year. But to give you a little bit of a lens of behind the scenes and how we've tried to position the use of our models and our guidance and some of the things we've learned along the way. And I think that sort of will beget a more informal conversation about what people are still worrying about, and hopefully a candid conversation of what we might know or what we don't know, and how we handle that uncertainty as we try to make very important decisions that affect the lives of a lot of people. So what is Policy? PolicyLab is a center at CHOP. It's in our research institute, where our care of children actually has informed an interdisciplinary model. We anticipate and respond quickly to the challenges that children and their families experience in communities. Our real world experiences with families inform a solution-oriented approach to the research that we do. And we've been around since about 2007, 2008, surrounding pediatricians and physician scientists and epidemiologists with individuals involved in public policy, social work, communications, public health, and have created a dynamic lab that's allowed us to translate very timely research towards the towards informing programs and policies that impact kids. And this is sort of our theory of change that you see on this model. We identify problems, we develop solutions, develop approaches through our research, we perform our studies, and then we seek to actually inform real world change through implementation. For this particular work, our COVID lab that many people follow in the region and beyond has, I put 4 of our leaders that join me and could easily be up here with me or are replacing me tonight. I've got Dr. Jing Wang, the one of the brightest biostatisticians I've met in my career at Penn. Dr. Brian Fisher and Dr. Susan Coffin are on here, two of our leading infectious disease doctors. Dr. Meredith Matone, our scientific director at PolicyLab, an expert in public health, who's really helped champion a lot of our school-based policy. So let's start out with what we'll start out at the end here, which is kind of what are the lessons I've learned in modeling the pandemic. Well, first is how did we get started? And much of my career has been focused on local area variation for children and families. And from the beginning of the pandemic, while we were looking at national models about how high that peak was going to be last spring around the country and what was going on in New York City, we recognized at PolicyLab, given the work over many years, that what was happening in New York or at the country, at the level of country, could not really inform what might be happening in Harrisburg, in Pittsburgh, in Philadelphia, and some of the rural regions around the country, and other cities around the country, and that everything is really local. And that's not just about our models, but that's also about school policy. If you've met one school board, if you've met one headmaster or superintendent, each unique school district, each municipality has their own challenges in terms of how to move forward with the pandemic, their business community, their schools, their school communities, their school staff. And this has really been a crash course on recognizing the need to listen and to really help people craft solutions that really work for them at the local level. Anytime you hear someone say we should be doing this and everyone should be doing that, it doesn't really inform what really happens at the local level. And we'll talk about that in some of our Q&A, I'm sure. The second is to avoid the pitfalls of confirmation bias. And with children and families, particularly around schools, we have to recognize, if we're having an honest conversation, where we might be prone to that. I think it's, if we were to ask the question, should children be in school, 100% of people would say absolutely. We know what the competing impacts are in terms of children not being in school. Yet we also need to acknowledge that children can get infected with this virus and they can transmit this virus. And how do you assimilate that information and avoid the potential bias of overreaching in terms of your conclusions of what might be safe or acceptable to get kids back to school, because you're really representing multiple communities, the school community itself, the families. Sometimes families, in different areas have very disproportionate risk. We think of families who live in the city versus who might live in the suburbs. We think about the school staff, who, these school districts have very large personnel departments. It may be a few hundred adults, in every building, and how they mix and interact during the day is probably even more important coming through in terms of the risk of transmission. And so we got to be really careful that even though we want to believe that we should just go back to school, we have to be very careful in assimilating data at different points in time and understanding what the limitations of those data are, so that we don't reach conclusions that are biased by our hope that we could get all kids back in school as soon as possible. And so we'll talk a little bit about that later, except that you can't make everyone happy. One of the things that I liked about the CDC guidelines that just came out this past week for returning kids to schools is everyone was unhappy with them, which means that they kind of rode the middle. And we'll talk about that when we get to the CDC guidelines, because when you're making policy, you have, really largely on the ends of the spectrum here, two camps: people who say, we should have everyone in school now, regardless of the risk. And then you have a lot of people who are very fearful and anxious about the risk to their own children, or the risk if they're a teacher or a staff. And somehow you have to find the middle in there so that you can bring people together as a school community, so that you have a functioning school day. Don't ever be too certain that you're right. Be prepared to change your opinions when you have new information that is presented to you. Be willing to have dialogue with people who may feel very differently than you, so that you can understand the kernels of truth and enrich your own understanding, even as you move forward. And then finally, I think most recently, I would say, don't become a prisoner to speculation. you want to act on real data. And I think right now there's a lot of information out there about variant strains of COVID, about whether or not we're going to see another surge. But the actual data is showing us a lot of optimism. And we can't make decisions in terms of the rest of the school year by becoming a prisoner to speculation. We have to act on real data, what we know works, and then make the best decisions possible so we can get kids back to the classroom as soon as it is safe to do so. So what are the tried and true data that I've relied on since the beginning that have stood the test of time since the beginning of this pandemic? Well, this is an example of a figure from a study that our team, including our infectious disease team at CHOP, reviewed early while we were doing a study on transmission from the early months of the pandemic. And this is from the Annual Review of Virology that reviewed the droplet transmission under different relative humidity conditions. So think of this as the environmental conditions under which respiratory viruses spread, and that includes temperature and humidity, and it also includes UV, which is can be very complicated. The seasonality of viruses is not extremely well understood, but we know that influenza virtually disappears every summer and comes back every fall and winter, and sometimes at different times, and moves, and with different strains. But like influenza, the SARS-CoV-2 virus spreads principally by large droplet transmission. What does that mean? It means that when people expel droplets from their mouth or from their nose when they sneeze or when they're talking or when they're breathing hard, they're primarily large droplets that will fall to the ground and disperse within about 6 feet, based on some of the science on the transmission of large droplet viruses. Yes, there have been anecdotal reports of aerosolized virus. Yes, under the right conditions, in a dank room without ventilation, in a bar, that we have reported it. But you can think about the spectrum of transmission of this virus as having a bell curve. And you might find some tail examples of airborne transmission, but principally this virus is a large droplet virus that spreads within 6 feet with sustained contact. How do we know that? Because we see the secondary attack rates in people's homes of about 15 to 30%, which is consistent with the way influenza spreads. If this were truly a fully aerosolized virus like measles or chickenpox, that would be closer to 100%. And so we have enough data to know how this virus now spreads, and our experience in healthcare systems, our experience in schools bears that out. Now that we know that, these large droplet viruses have particular properties depending on the environmental conditions. So what you see here are 3 different climates: tropical, and then you have the spring and fall, the temperate season, and then the winter. Well, in tropical, you have areas, you have very high humidity. You may have high indoor relative humidity. And in those conditions, the virus actually has a lot of viability. Think of those sticky surfaces or their wet surfaces. The viruses can live on surfaces a little better. A lot of the infections we saw, particularly in tropical areas or during summertime, included a lot more GI symptoms. And to the degree that there has been fomite transmission, you see it more during the summer than you would during the winter. And so we recognized that possibility, and it also made it incredibly important, let's say this past summer, to recommend that hygiene practices in restaurants were extremely important throughout the summertime. But the true properties of this virus are really around the respiratory droplet spread. And you can see that respiratory, that the proportion of droplet nuclei during the summer actually is quite low. And in spring and fall, those are the sweet spots in terms of reduced transmission, particularly for respiratory transmission and certainly for fomite transmission as well. And in our own modeling study, we found that the spring and fall would be the primary times of low transmission. And we saw that in April and May last year. We saw that in September, October. It led to us to try to delay the reopening of schools till late September because we knew we would hit a nadir in transmission. And that's what occurred. But we also knew, based on the seasonal properties, that as we got into winter, if we built too much disease burden, we would end up in the 3rd category, where all the signals were high. At low temperatures, the virus would be likely to suspend in the air longer. It might travel longer distance to the degree that it could aerosolize. It would happen more during winter type conditions. And it was a highly viable virus, and that's wintertime spread of a typical respiratory virus. And in many ways, this virus has replicated that given the peak we just went through. This is from the study our team published in the JAM Open Network. And I'm just going to describe to you. I'm not going to show a lot of slides because it can get complicated. But what you see here are the first 211 large counties that went through the coronavirus crisis of last spring. And we modeled data on what's called the reproduction rate, which is the transmission rate that largely measures the number of infected people for every given infected individual. And you can see that on the y-axis on the left. The sweet spot that you want to know about here is the number 1. Below a reproduction number of 1, the virus is no longer propagating on a 1-to-1 ratio, and so therefore your overall community transmission declines. As you get higher towards 2, 3, and above, that's when you're really starting to exponentiate and the virus is really doubling. And so what you're seeing here on this slide are the average estimated reproduction numbers under different environmental conditions for about 200 plus counties across the United States of America. What you see on the x-axis here is the density, the population density of that county, with less densely populated rural counties on the left, moving to very populated counties, including places like New York City and Philadelphia on the right. Now, you have 2 panels here, one that's at 2 degrees Celsius, which is right near freezing, and one is at that sweet spot in spring around 50 to 60 degrees Celsius, Fahrenheit. Here you're close to freezing, like we are right now. We knew last spring, based on the estimation across population density, and if you looked here based on what we have here in pink and in green, in terms of the dots, are these same counties at different levels of social distancing. If your activity is highly reduced, like during lockdown, which was a 70% reduction in the amount of travel to non-essential businesses, that is depicted by the green. The pink is more where we've kind of averaged through the summer and into the fall, about a 35% reduction in our large cities in terms of the amount of mobility. Now that's gone up recently because of the winter and what we've gone through. But what the pink is giving you is if we're more mobile, and what the green is giving you is if we're really restricted in terms of what we're doing. And this is based on actual data. And what you can see when you're in very cold temperatures, even when you're highly restricted in terms of the amount of mobility of people in your county, most of those counties had a reproduction number or a transmission rate above 1. We knew that even with high levels of restrictions, that we were going to see significant amounts of transmission in the winter. And if people were not observing some level of distancing, those numbers were even higher. Yet during the summer, if we were still under a lot of restrictions, we were going to see relatively quiet summers like we saw in the Northeast. But the moment we relaxed, because there was a lot of naive individuals without immunity, we would see reproduction numbers even in summer. And this confused people, reproduction numbers above 1 as we move towards summer. And particularly as people started to gather, we actually saw some places with significant transmission. But at the end of the day, what matters is what's occurring here on the left, which is that in wintertime, as we move to the temperatures we were in now, the shorter days, we expected what was about to happen and knew that our hardest moment was going to be likely in November and December. So let's talk about how we made decisions about doing interventions. And I think one of the biggest criticisms that people have leveled towards folks who have been doing the public policy on COVID is that people haven't been consistent in their recommendations. They've changed. Well, we have to recognize this was a novel coronavirus and we were gathering data throughout this pandemic. And I'm reminded of John Maynard Keynes' quote, "When the facts change, I change my mind. What do you do?" And so, I I have really thought about our journey through this pandemic from the perspective of public policy as one of many crossroads, where you had to really distill every 6 to 8 week interval down to what we know and what we don't know at this moment in time. From the summer when we knew there would be less transmission and potentially less virulent transmission, to the winter where we knew we were going to surge around the holidays. And then adding information like, for example, with the schools, um, how much we really knew about the amount of transmission that was occurring among children, among school staff, and then what proportion of that was actually occurring inside the school building, particularly under the presence of strong protocols that involve masking and distancing and hygiene and sick policy. So let's talk about those different moments in time. And so this was the models, our COVID lab models now in about 823 counties across the United States, the actual transmission rates, and then converts that to a 4-week projection shown here in the dotted line of what might happen in the next 4 weeks based on the amount of transmission that a county has had. We've done lots of validation with this work. These models have informed the coronavirus task force in DC in discussions with governors around when to implement public policy around the country. And here I'm showing you a model from last summer in Philadelphia County in our own region. Now, when you look at these models, and I've told people over time to interpret these models, we only go out 4 weeks because you never want to go out further than 4 weeks because your uncertainty grows as you move further out. Our models are best viewed as a series of forecasts over time. And if you see the slope increasing every week, then you might be concerned. If you see Delaware County and Montgomery County also increasing, it lends increased confidence. And then certainly if you see your test positivity going up in the region, if your hospitalizations and ER visits are climbing, all that information goes into what creates our blogs every week in terms of what's happening with transmission. Now, the most important factor in the models that develop this prediction are the actual rate of growth in the cases or the transmission rate over time. The slope of this projection then is also varied by the test positivity that we're seeing in the region, how densely populated a region is, how much social distancing is occurring in the region at that time, what's happening in the neighbor counties, and what the natural rate of growth is for that county. We want Philadelphia to grow as Philadelphia has grown, not like New York City has grown, or not like Pittsburgh has grown. And so all of that, there is a science beyond here that involves a lot of validation that creates this predicted curve. Now, beyond that, I'll tell you that back in last summer, as we got prepared to open school, what we saw was a lot of increasing risk coming, particularly up the mid-Atlantic coast as people blew out the rest of summer. And you can see clearly by August, we were seeing a lot of case transmission pick up in the Philadelphia region, such that our models week to week in every county in the Philadelphia region were demonstrating we were going to hit Labor Day with increased cases. That led to a recommendation to kind of postpone the resumption of in-school education for a couple weeks past Labor Day to allow things to settle down. We knew that temperature and the weather was going to be favorable, and we knew that people were going to start hunkering down again, and that's exactly what happened. People look back now and say, look, given the amount of success we had with in-school education late into the fall, shouldn't we have just opened on Labor Day weekend? And I understand that argument. Certainly that can be made for children in elementary school, those first couple of weeks of September. But that said, the car crashes that don't happen are the ones that you'll never see. And I can tell you that in our region, those 2 to 3 weeks may have kept our schools open right up till Christmas. In the Midwest, they opened immediately, and particularly in the upper Midwest, they were surging by October. And it's not to say that the transmission was happening in school, but schools, whether it's happening in schools or outside, what was happening was a disease burden was building in children. It was often associated with activities that surround the school day, whether sports or activities that might happen after school. But hitting pause for those first couple of weeks may have reduced the burden through which we went through the wintertime within families, within households and gatherings. And we'll just never know. But at least understanding the decision was based on trying to reduce the disease burden so that we wouldn't be quickly closing schools as we move through the fall. Now, moving along, probably the most controversial moment of the pandemic for our team was November 10th. Some of you may remember that. I was quoted in a newspaper article with the Philadelphia Inquirer warning the region that we had a potentially catastrophic situation on our hands and that our hospitals could really struggle if we did not start to really look at the holidays as a moment in time to try to prevent transmission at Thanksgiving and Christmas. This explains why I spoke to the paper that time and why I made the very difficult recommendation, because we had supported school reopenings the entire time and have worked with many schools throughout the region to take a pause just around the holidays themselves. You can see Thanksgiving down here on the bottom, and around Christmas, which occurs later on in December. Why we chose to say take a pause for a couple of weeks, and Montgomery County followed in suit with that recommendation, because this here are the actual transmission rates, those reproduction numbers, 2.5 weeks out from Thanksgiving. They were extremely high. And the kind of case incidents we were beginning to see, and what we were seeing from the upper Midwest, rates that exceeded 1% of the population every day, every week being infected. Those types of rates going to the Thanksgiving table 2 weeks later would have resulted in an unprecedented surge and would likely have overwhelmed our healthcare systems. So I came out on November 10th and I said, I think we need to take a pause and ask everyone to quarantine, not just kids in school. I did not make the presumption that schools were less safe than other areas. I was focused more on Thanksgiving, that collectively everyone, families, should make the prudent decision to keep their kids home from school. Everyone, if they were planning to visit family on Thanksgiving, which was discouraged at the time, they would best do so by taking a week and a half off and quarantining, and then resuming school the week or two after, and doing the same thing around Christmas. That message got out very quickly. I got a lot of bad emails about even suggesting that, but you can see the rate of rise in the transmission rate, and within 2 days, and because there of that article, transmission started to fall in the region. That was supported by PJ Brennan from the University of Pennsylvania. Came out with a very, very important op-ed just a couple days later, imploring our leaders to step up. And just the following week, PDPH, the Philadelphia Department of Public Health, announced its new restrictions. By the time the restrictions started, we had well decayed the transmission rate, entered Thanksgiving with a stalling transmission rate. And what I think we did over the holidays, and we beat nearly every region in the Northeast, is we really decreased the size of these post-holiday peaks. I really do believe those moves in those 2 weeks around Thanksgiving saved lives. And that's hard to hear, because we also said, I think our message was misconstrued. People heard PolicyLab closes the schools. Well, that's not what we said. We just wanted to protect the holidays themselves. And we were the first ones to say reopen schools come January. And with supers in the area, superintendents and headmasters, we were preparing to resume school as soon as January hit, once the worst of this was over. Now, where do we find ourselves today as we get past December? Now, this is from our website. You can see just the variation in terms of the test positivity rate throughout the region, as was reported on our website this past week. And I encourage you all to go to policylab.chop.edu. You'll see, for those people who follow the weekly case incidents, we plot every county, and this is Philadelphia County today. We plot the positivity rate. And the most important thing I want you to see now is just how well we've begun decaying since December, where we reached over 400 per 100,000 in Philadelphia, and now we're back at about 200 or just under 200 per 100,000. We've declined in half the weekly transmission that we're seeing in Philadelphia. Our positivity rate is dropping to 5%. It's even lower in some of the collar counties like Montgomery, Delaware, and Chester. We're moving in a favorable direction. Yet we're hearing about new strains, variant strains that may be more transmissible. And we're also hearing, um, from experts who worry that we might have another surge and what may be coming. And this is where I get to my last point about prisoners of speculation, is that as concerned as I was in November, I'm actually really optimistic right now. This is a beautiful decay in our test positivity rate. If we go on to look at our actual hospitalizations and the ICU beds that are occupied in Philadelphia County, you can see in the light blue here our case transmission. It's really coming down now. And this is now on the y-axis, the daily case rate per 100,000. But our hospitalizations are declining quickly. And I could show this to you for every county in the country and every state in the country. Is hospitalizations are declining everywhere. We have only Texas and California still have fairly high ICU rates that I define as being over 30%. But in the upper Midwest that really led the surge in early fall, they've really hollowed out where their ICU capacity is now less than 10%. And this kind of decline gives me a lot of optimism that the seasonality of this virus is really starting to come out. And that combined with natural and acquired immunity from the vaccination is really overwhelming the innate ability of this virus or the strains to really multiply as we move towards spring, so long as we remain somewhat patient and careful. We have a window of opportunity that it's opening for the first time since fall, where we can begin returning even more children to the classroom, and I believe optimistically returning to normal school days for many children throughout the region before the end of the school year. For those people who say, well, that's Philly, what's going on elsewhere? This is Iowa, one of those states that have really hollowed out. And the reason why I wanted to show you Iowa, and not to say I would recommend it in Philadelphia right now, is Iowa went through a really difficult time where they overwhelmed their hospital capacity, so much so that the governor there, who refused to institute a mask mandate, eventually had to, because the hospitals were overrun. Now, since that time, almost immediately after she instituted the mask mandate, hospital census has fallen really nicely. It's now lower than it was last September. Their case incidence has bottomed out. And in the last few weeks, that's happened even as she's removed all the restrictions. They blew through Thanksgiving, Christmas, New Year's without much of a resurgence, a little bit of a resurgence following New Year's, but nothing that sustained. And it's that kind of data from a place like Iowa that if they're not resurging themselves right now, given how relaxed they are, what's the likelihood that anywhere else is going to resurge? And I think it's really low. So long as people are patient, we have an opportunity to move beyond the worst of this pandemic in the next couple months. And that's now leading to what do we do now about schools? And so what do we do? So the CDC released recommendations this past week that, I understand the challenges they had. They're making recommendations for school boards around the country and headmasters around the country, from the Philadelphia School District to the Lower Merion School District to the small private school to the small rural school to the small charter schools across the entire country. So they sort of bound what I call are the anchors or the lane markers for how to think about when to resume normal instruction, because they're seeing the same data that I'm seeing, but they're also recognizing that when we got to the highest moments of this in November and December, even though most schools did not have a lot of transmission, we started to see a fair number of outbreaks across different schools in the regions, not everywhere. And I still think most of the transmission was occurring outside of school because these safety plans that we developed worked extremely well. But that said, they want to be careful. They don't want to see these variant strains take hold again in the late spring or extend the length of this pandemic. Some people would think they are too conservative now. But I tend to look in terms of what they're relatively saying. And so we right now are above 100, but I suspect some areas of our region within the next few weeks are going to move into the orange range, where they would recommend all levels of school from elementary to middle to high school to be open in hybrid, or at least with 6 feet of distancing between the desks required. For most places that requires accepting some of our private schools, that would require a hybrid sort of schedule. But it's not unlikely that by spring, we're going to be down getting close to this moderate transmission level. And I suspect, given the rate of declines that we're seeing, if we can ride this momentum, we're starting to prepare a lot of schools in our region to certainly start with their elementary schools and begin surveying their school communities to get back to normal school days, starting with elementary kids. If, as we expect, we continue to see declining transmission, move towards their middle and high schools. Now that's in the suburbs. In the city right now, we're just trying to get the school district of Philadelphia open. And I believe that, based on these recommendations, even in high, we have ample evidence that the early education kids, and particularly the K-2 that they're recommending in the school district of Philadelphia, can return safely in dedensified classrooms. So I just wanted to put to interpret what I think is more of a relative recommendation here is to be patient over the next few weeks. For those of you wondering, when are we going to go back to a normal school day? I think the likelihood is spring is going to be a good time because you can take more advantage of outdoor space. You'll be in warmer weather. That natural seasonality is playing in your favor, and you'll just have fewer kids who have COVID knocking at the door. We've also introduced a testing program that can help reduce the number of contagious individuals a little bit more. And I think the entirety of that is providing a really nice window of opportunity coming towards April here, where I think a lot of kids are likely to start returning to the classroom, beginning with our elementary school kids, and then pushing on into our middle and high schools. So with that, I'm going to stop my comments there because I want to give you guys some time to ask some questions, and I'll turn it back over to Jayatri.
Great. Thanks, Dr. Rubin. And it's nice to hear a voice of optimism given where we've come from and what still lies ahead. So thank you for walking us through how you go through some of those models that we base these decisions on. So we got a lot of questions ahead of time, which I've kind of organized into some of the themes that you touched on, and I do encourage everybody to put more questions into the Q&A. I wanted to touch on a couple of questions that relate to some of the math you talked about in terms of the modeling. And especially thinking about as more people get vaccinated and as people, just because of the caseloads, become immune to the disease, how does that get factored into the models that you build?
Oh, it's something we do what's called a random effects model. And so, when I said that, I made a comment earlier on that we take into account the natural growth. Now, we also are now including in our model the cumulative prevalence, at least as a measure of some of the acquired infection and seroprevalence that we've seen in the region. And it's a relative marker. In fact, it's this random effect at the county that as the cases start, the most important elements are the actual rate of growth itself that lead to the prediction, but also what we call the random effect of counties. So counties that are further along will grow more slowly than counties that have less seroprevalence, and our models detect that.
Okay, so you kind of see that on that county by county basis as you're looking at the rate of growth.
Yeah, so if we saw like a tremendous amount, like when, our models, so for example, in Iowa, in the counties in Iowa, when they just opened up the doors and said, let's go back out, our models didn't just say, go ahead and spike their cases, because we knew that they were no longer responding to distancing and lack of distancing in the same way because they were further along.
And I want to give a shout out to the person who asked about whether any of this data is available publicly so that amateur science and math wonks can do their own models at home.
Absolutely is. So the answer to the question is yes.
Awesome. Where should we look?
USAFacts.org has for a long time been our source of data. They have their GitHub that's publicly available. We did not have to do a data use agreement for that. And New York Times also publishes their data. I think there's a third site that I'm forgetting right now, but we've been the Johns Hopkins site also has a GitHub that provides data, and so we use all three in a variety of algorithms depending on who's updating their data the quickest.
Awesome. So you too can do this at home.
You can. I don't recommend it for your health.
Okay, so I wanted to switch gears now because obviously some of the policy implications that you talked about have to do with schools, and there are lots of questions about that as well. So one question, just to kind of, I think, clarify in terms of where that decision making happens, you mentioned that everything is local. How are policies on things like in-person schooling versus hybrid versus remote decided? Is that a state decision? Is it a local decision? Does it differ by state?
It's really a local decision. I mean, people get, they hear your public health officials, but the public health guidance, for the most part, with the exception of a couple moments in time where things were required, um, during late November and December, middle and high schools were closed in the city of Philadelphia. Those private schools and other charter schools and Catholic schools, and even though the district was already closed, they could not open. Many of those schools were also facing significant shortages of staff. I mean, that has not been talked about enough. I mean, the principled stand to make sure kids continued in school when there was a custodian maybe watching a classroom of 5 kids who were doing math packets. We no longer had a functional school day in a lot of schools. But outside those moments when there was public health requirements, most of the guidance you've seen from public health are recommendations, including the CDC guidance. So it's not law. And so it ultimately rests on the decision of the school board and that governs that school. And then they lead a conversation with their school community, with their superintendents, with the school staff themselves. And I'll tell you, every one of those negotiations is its own negotiation. And sometimes they follow the public health guidance, the letter of the law, and sometimes school communities go in a different direction. And they each have a good knowledge of the appetite of their school communities, what their structural campuses look like, how well their protocols are going. I have a lot of admiration, particularly for the public school superintendents that I've worked with throughout the area, who are real heroes that people don't know their names, but have had to navigate so many complicated people, and they are trying to get kids back to school, and they're trying to keep kids in school, and it's a hard job.
Yeah. So, I mean, as you talk about some of these hard decisions to make, and I think we've got a couple of questions related to that. The first one I want to ask you is, we hear a lot about opening elementary schools because especially high school students seem to be transmitting and contracting the virus at higher rates. And yet, what impact are we seeing on the mental health of teenagers, and how do we care for their needs?
But clearly, I think it's a trade. Everything's always been a trade-off. I think we have to be careful to think that the school itself is the panacea for what's going on in our teens. Clearly, we're having a mental health crisis that predated the pandemic and has only been made worse. And for many kids, they need to be in high school. I've actually encouraged a lot of schools. The decision to go hybrid doesn't mean every kid has to go hybrid. If a kid needs to be in school, I've seen some schools do some really nice things. Some kids are full time, and there's a lot of opportunity there. But it forces me to think. Well, around November when we were closing schools, the recommendations about elementary school are supported by the science, but we shouldn't forget about our middle and high school kids and trying to get them back as soon as possible. And one of the reasons we developed that testing program, Project ACET, that I spoke about, that's now available throughout the region, was to particularly help the middle and high schools get back because of those concerns. And particularly as you weigh, all along you're weighing the risks to families from the disease itself, and then the risk in terms of the competing consequences. And as we move into a window, I think that each school district is deciding when are they comfortable with the safety threshold that they've met, because they understand the competing risks, and their goal is to get the kids back into school and back to their services as soon as possible. We've actually, for the kids with special education needs, we got them in even earlier because their services in school are so critical in terms of their daily lives. And so they've actually been back in most schools in the area, even at the school district of Philadelphia over the last few weeks, resuming some of the services there.
One proposal that we're hearing is that perhaps schools should stay open in the summer to make up for lost time. Is that something that you're seeing being considered on a widespread basis?
I think that's on the table. In terms of, I haven't had a lot of conversations about what schools are planning for the summer, but one of the reasons we're setting up the testing program is to allow them to make that decision. I think there'll be a lot of other students who'll say, look, that's still I think we have to be careful in terms of the choices we make and how we do them, also recognizing that the kids have just been through the pandemic. And while the absence of school has been really important too, the social isolation is key for them as well too. And so, so I think each school district is going to make its own decision about the availability of summer school. And I think it's a complicated decision, but I suspect we'll see summer programs being made available.
And then one last question about how these decisions about school are being made. Someone's sharing that in New Jersey, the courts actually came into the picture to support teachers who said that their classrooms were unsafe. Is that something that's happening on a widespread basis as well, or are these decisions still largely being made on a school district basis?
I think they're largely being made on a school district basis. There's some level of organization above that. And I'll tell you, there are a lot of schools that were open, but like I said, I think people didn't have not a lot of folks did, even in the schools that were open and open pretty well, a lot of schools had to close functionally. The buses weren't available in late fall. There weren't enough teachers in the classroom. They just couldn't functionally have a school day. But it's been made on, this literally has been a discussion and a negotiation at every school level, right down to your independent schools, et cetera.
Yeah. Yeah, and I think that balance that you talk about in terms of the social isolation versus school being the solution to that. I think that's something that we'll continue to look at. Somebody else is asking, as we think about summer and day camp and sleepaway camp, are these the same factors that we should be thinking about?
I've told my friend, I have a good friend who owns a sleepaway camp. I think Governor Cuomo just came out saying camps are open this summer. I believe camps are going to be open. I think that, I think of everything as a spectrum of probability, like you have to be, I'm seeing great declines right now. We're a little worried about those variants. We're worried about the pace of vaccination, but at the rate of decline we're seeing right now and the seasonality that we're seeing really declare itself, I think there's an increasing probability that things are going to get really quiet here in the late spring and summer, and we're going to have a lot more freedom than people suspect. But we're also going to worry a little bit about next fall and winter and just how far along we are with vaccinations. And so I suspect summer activities are going to look pretty good this summer.
I know, I think my kids will be happy to hear that.
Yeah, so the thing is, I think we have to be careful. I think there's a lot of speculation, like I said, going out there about what might happen, what could happen. It's not based on the actual data.
Right.
And I think it also creates apathy. And I think we have to provide room for optimism for our kids, for our families to recognize that actually, if you're looking at this probabilistically, there's a lot more optimism than there is negativity. And I don't know whether some of the messaging we're receiving now is more to encourage people not to rip off that mask and run out and jinx it. But I think it's important that people see the optimism. It's been a long year for everyone, kids included, their families, the older folks in our communities, our workers, our teachers, everyone has really suffered a lot through the pandemic.
So I want to switch gears a little bit and talk about vaccination because, as you said, the rollout has been a little bit slower, but that is one of the factors that is a cause for optimism. And many people had questions about the vaccine. So let's talk about that for a little bit. So we've got 2 vaccines that are being distributed right now. Another one from Johnson & Johnson that is under review by the FDA right now. Is one better than another?
Look, I think they all provide protection against transmission. None of them are perfect, and I think there are concerns of decreasing efficacy with a couple of the strains. But to me, the goal is whatever vaccine you can get right now, you get it. And the more we can collectively vaccinate the population, the quicker we're going to see these declines. And the more you see these declines, it means the virus can't propagate, and that includes those variant strains, and the mutations will be slower. And so for me, I would not sort of try to mince differences between the vaccines, and just as when your name is called, roll up that sleeve and go sign up.
And so as we're learning more about the effects of these vaccines, what do we know about how long they provide immunity and whether they're effective at reducing transmission?
Well, those are some unanswered questions. We don't know how, we've certainly seen infections after the first vaccine. We've already seen a couple of infections after the second. I mean, even when you say 95% efficacy,
Right.
that means 5% did get infected. But I think the more important question, I think we should assume that it's possible to have transmission even after vaccination. This is going to become likely an endemic virus. And what you need, and that's why we're starting to see the seasonality of it. And the
Right.
next thing we'd like to see is a reduction in the virulence. And so I think a more important question that I think about is that as we start to see second infections, either following a first infection or following vaccination, are they milder than where they were previously? And as that virulence comes down, well, the calculus changes, right? And if the hospitalization and fatality rates come down closer to influenza, we don't do everything we do for influenza. And I suspect that if you ask most public health folks, they expect that this will likely become an endemic virus over time, and the virulence, the severity, even if you are reinfected or even if you retransmit, is not going to be as concerning. And so we'll go back to some level of normalcy, but hopefully learn some lessons, I think, for the future in terms of how to prevent transmission. Like flu is a bad player as well too. We don't talk a lot about flu. We lose 50, 60,000 people a
Right.
year to flu. It certainly disrupts school a lot. But in Japan, kids, when they're sick or have a cough, they come to school, but they wear a mask. We might think about sick policy a little bit differently in terms of our winters. We might position school-based health and maybe school-based testing, particularly during winter time when we do go through our, the COVID peak or the influenza peak, to try to blunt those peaks a little bit more because it's good for everyone in the community. I don't see hybrid instruction surviving into the future, and I think a lot of people are probably happy to hear that. I do think there'll be some opportunities to think about virtual instruction. There have been some kids who've done better in virtual instruction, and some families who may not be
Right.
satisfied with the pace of vaccination, even at the fall, where they're going to request a virtual curriculum. But I suspect we're going to be back in normal school days and try to learn some of the lessons for winter prevention and know when to escalate them as we move forward, but without the hybrid and trying to resume our normal lives.
So we might not be wearing masks forever, but we might adopt these policies of, or even just habits, really, of masking up when we're sick, the way that folks in
It's a
other
little bit more,
countries do.
it's more of a precision approach from a population health perspective. And that's principally what I do at CHOP, is to try, to do the right intervention at the right time, do it for only as long as possible. You want to have it as least disruptive as possible. And obviously we've had a lot of disruption this year. But I think we're moving towards better days. And I think it's important that people understand that.
So one last question here, because you brought up the flu, is that this year we are seeing a dramatically lower level of flu going around than we have, in past years compared to compared to what we're seeing with COVID. So what's the difference here?
Well, it just shows you how effective those masks can be, right? Now, we're not a naive population to influenza. So, it shows you somehow some of that sort of protective immunity combined with the masks and the social distancing has really squashed flu. But in a naive population, COVID really was impressive in terms of what it was able to do. But I suspect as our acquired memory to COVID in our in immune systems grows, um, it's going to be harder for COVID to propagate the way it did over the spring, summer, and winter. And I suspect we're less likely. I mean, we have to go through this summer to see what it's like, but I suspect the likelihood of significant COVID infection over the summer is going to go way down compared to where it was last summer.
So a couple more questions about vaccines are coming in. One is, can you take too much vaccine? Should you get more than one if you have the opportunity to?
Well, there's two doses in the vaccine right now. I mean, I think we'll have to, there was a lot of urgency in getting the vaccines to market. We're not moving, we're all disappointed by the pace of vaccination and the inventory problems we're having in the region and the country right now. But even as we do this, I think the scientists are still working. They haven't hung up their cleats. They're starting to work on booster doses and whether this becomes like the flu vaccine, with every couple of years you might get a booster. I mean, there's still a lot of unanswered questions as to where we go from here. But the most important was to start developing some immune memory among the population to help this virus. We're not going to eliminate this virus. I think that's highly unlikely. Uh, but um, but to get it more into an endemic virus like our other seasonal respiratory viruses, and then hopefully usher in a period where we can get back to some normalcy in our lives.
And one last vaccine question is, what's your prediction of when we'll have vaccines for kids?
The trials are going on right now. I suspect by summer and early fall we'll be back. We're already beginning to vaccinate kids at CHOP, particularly with complex conditions over the next few weeks. The adolescents, and they're doing the trials in kids right now. They're a little bit different than the adults. They're really just trying to look for the right dose that will give kids the right immune response that's comparable to the adults, and also show that it's safe in kids. And I suspect it'll be offered to kids probably later this summer and early fall,
That's
depending on vaccine inventory.
yeah.
Yeah.
That's really exciting, I think, for many of us. So as we look towards the fall and even further out, I think the question that's on many people's minds is, when is it going to be safe to do different things after you get the vaccine? So whether it's getting together with people who haven't yet gotten the vaccine, or going to restaurants, or starting to travel, when can we get that semblance of normal?
I think when that case incidence really drops, I think, and certainly, I mean, everyone has to appraise their own risk based on what their tolerance for risk is. But I think that and you have intervention short of that as you travel, wearing your mask if you go on an airplane, et cetera. I think it's still a little bit hot out there right now, but I think by April, May, I think we're going to be in a position that hopefully in many areas of the country people are going to feel more comfortable. I've always believed that our goal was to manage transmission, to equip people with the individual choices to make smart decisions for their families. That we could, we had to, as soon as possible, move away from the types of restrictions that require things of restaurants, et cetera, and for better or for worse, to try to help us manage our own individual decisions in lives. And I think that's where we're moving, is individual responsibility. And for some people, it'll be earlier than others. But I think we have to move past, like I said, our fears, are to become the prisoner of speculation, for example. Like right now, the variant strain, the reports of every new variant strain, I don't think are particularly helpful to most Americans. This virus is going to mutate. We should not be surprised about that. And so what matters at the end of the day is, as these rates come down, and they come down to really low levels, people can start resuming some of the things they used to enjoy doing.
So then, a couple of sort of big picture questions. First of all, I think one of the bright spots of this pandemic has been the pace of science that has led to the development of these vaccines so quickly. Do you think the process that the vaccines took from discovery to distribution will speed up for the long term based on what we've learned from COVID, or is this kind of a perfect storm of factors that supported?
I just think, I mean, I think there's some amazing stories here. I mean, the messenger RNA vaccine, that had not been done before, and it got done in the span of a year. The pandemic at a couple of companies, at Pfizer and Moderna. I mean, it's amazing. It's really breathtaking if you think about it.
And I guess I would add to that, though, is that there were decades of basic science behind that.
Absolutely.
And so
when it shows you when there's the will, and when the will is there, and now we have such an advanced technology and the importance of science, the capabilities, this would have been, it just to kind of think about that is pretty breathtaking, the speed by which this vaccine developed. And even though we're behind, we've already vaccinated, I think, close to 40 million individuals with at least a dose in this country. It's just amazing that within a year that has occurred.
So I think that gives us some confidence to think about this next question, which is, what's the likelihood of future pandemics? Are we going to deal with this 10 years, 50 years, 100 years?
Well, again, that we don't want to become prisoners of speculation. But I think that, the evidence would suggest over the last 20 years that the number of potential pandemic viruses has grown. The coronavirus family. This was not our first rodeo with the coronavirus. We had SARS, the original SARS, and MERS, that did not end up becoming a worldwide pandemic. And so, part of, we can suspect whether it's related to climate change or whether it's related to just just zoonotic pressure, given the increase in our population around the world and our activity. That the risk for pandemic is there, but I think we'll be smarter the next time around. And I also think that our scientists are. I read a really interesting article the other day about the development of a pan coronavirus vaccine, given that the last three have been coronavirus. That again, some of these boosters may actually be serving to provide immunologic memory against potentially future iterations, so that the impact of those viruses will not be as significant.
So last question here is, what do you think is the most important lesson that we've learned that might help us in a future public health crisis?
I think consistent messaging on the things that work, keeping it simple. I think if we'd had consistent messaging around masking early on, particularly around masking, and throughout the pandemic, we'd be in a far better place today in terms of the ultimate outcome. I mean, we're coming to the other side of it. We got through it, but I think there was extra suffering there that probably didn't need to take place if we had more consistent messaging around the use of masks.
I think that's a really valuable thing for us to think about as science communicators, no matter whether we're talking to our family or our friends or at a museum or at a policy lab. I think there's a lot of things to reflect on in terms of how we talk about disease now that it seems like everybody's had a crash course in science and has their own expertise. Well, Dr. Rubin, thank you so much for joining us tonight. We've covered a lot of ground. I hope we've answered a lot of the questions that you had. We had more questions that I apologize we couldn't get to, but please keep joining me for my monthly COVID conversations. We talk about a lot of these issues with a variety of different guests, and so hopefully we'll be able to continue talking about the questions that are on your mind. Before we finish up, I just wanted to thank you again for your ongoing support as our members. And of course, I want to remind you that we are open now, again, with new hours and enhanced health and safety protocols. And our brand new Crayola IdeaWorks Creativity Exhibition is now open, and it's a lot of fun. So as part of our commitment to both your safety and the safety of our team members, admission is at limited capacity, so we encourage you to go to fi.edu to find out everything that you need to know to make reservations in advance and what to expect. So please, everybody, stay safe. Join me in thanking Dr. Rubin again, and we look forward to seeing you very soon. Take care and good night.
Have a good night, everyone.